I'm very honored to be able to introduce Hilary Samples, who's one of the core members of our center. She's assistant professor of health systems and policy at the School of Public Health and associate director for research in the Center for Health Services Research at IFH. She joined Rutgers after finishing a postdoc in substance use epidemiology at Columbia and earning her doctorate in health services and policy research from Johns Hopkins School of Public Health, where she also completed training in population mental health and bioethics. Her work broadly aims to identify risk factors for behavioral health problems, analyze patterns of prevention and treatment services, and evaluate the impact of health policies by assessing trends in health services and patient outcomes. Her current research applies novel methods to characterize prescription drug treatment episodes and improve understanding of care pathways and outcomes for complex patient populations. And some of Hilary's recent papers, very meticulously done in moving the methodology forward on using large administrative databases, have been extremely important in thinking about both opioid use and medications for opioid use disorder. So with that, I turn it over to Hilary.
Thank you, Steve, for that very kind introduction. Great. Everybody can see? Great, thank you. Okay, so as the title and flyer suggested, I'm going to talk to you all today about prescription opioid treatment among individuals with chronic pain, with the ultimate goal of looking at the association of prescription opioid treatment patterns and risk for adverse opioid-related outcomes. So just the broad overview of the talk, I'll talk a little bit about some of the motivating factors for the study that I'll present in more detail, with some additional background, and of course the typical standard methods, some preliminary or really ongoing results, and discussion and next steps. If you have questions throughout, I don't even know if I'll be able to see the chat, so please feel free to interrupt. I prefer not to talk for an hour, so discussion and questions are more than welcome. So I think if you're here, or if you've been in the world at all over the last 10 years, maybe 20 years, you know that we're in the midst of an opioid epidemic, marked by rising rates of opioid addiction and abuse, depending on the data source you look at, and record numbers of both fatal and non-fatal opioid overdoses. The epidemic has largely been broken down into 3 waves, with wave 1 being attributed to prescription opioids and characterized by prescription opioid overdose deaths. This is sort of what is motivating this work, which is not only relevant for the types of data sources that are widely available and high quality, but I think also really important in terms of the practice and policy implications that it has. So about 20 years ago, the increase in prescription overdose deaths started. Roughly 10 years later, we saw this transition to heroin overdose deaths. And in the last 5 years or so, we've seen that synthetic opioids, or really adulterated illicit drugs, have been the most urgent concern. And I think it's obviously, as a public health person, really important to focus on some of our urgent concerns to try to solve this problem. But also, I think we can learn a lot from some of the earlier waves and causes of the epidemic still. So a couple of years ago, the CDC published, I think it was an MMWR paper that showed that overdose deaths were not only accidental overdose deaths were attributed largely to opioids, but also the proportion of intentional overdose deaths or suicides was also increasingly attributable to opioids. So being someone working sort of at the interface of mental health and substance use, I started looking into this and realized there was a gap in the literature. So most of the evidence was really focused on the relationship between suicidal behaviors or suicide and opioid addiction or abuse. But there really wasn't much published on the relationship between medical opioid use and suicidal behaviors. And this struck me as particularly important because pain has a really long-standing established relationship to suicide, and it's also obviously the primary indication for prescribing opioids. So I wanted to look at whether the risk of suicidal behaviors that was associated in the literature with opioid abuse and addiction also extended to just purely medical opioid use. I'm not going to get into the details of the study, but I used causal inference methods to try to understand sort of a counterfactual scenario in which individuals with prescription opioid misuse or abuse had instead just used prescription opioids medically. Oops. Yeah. Oh, there we go. And what we found was, sort of consistent with the previous literature, non-medical use or abuse had an independent association with risk of suicidal behaviors, but we didn't see that any evidence that medical use was associated with increased risk of suicidal behaviors. That said, I had looked at subgroup analyses, and in those showed that some subgroups actually had similar risk of suicidal behaviors with either medical or non-medical use. And those groups included individuals with multiple medical comorbidities and lower self-rated health, which really suggested to me that there were some potential unmeasured conditions or symptoms like pain that were mediating this relationship between opioid use and suicidal outcomes. So in trying to get a little bit more at the relationship between pain, opioid use, and adverse outcomes, I dove a little bit more into the literature, and this is what has motivated sort of the current work. So by way of background, we know now that some of the trends that we've seen in opioid prescribing over time really stem from treatment for chronic pain, which is a pretty substantial problem in the US. Even though the estimates vary pretty widely, it's not a condition that is measured very consistently. But even the lower estimates equate to over 25 million Americans, and those rates have increased over time along with prescribing. And we have seen some declines in opioid prescriptions, but the rates are still really high compared specifically to the pre-epidemic levels. And prescribing is concentrated in some of the disadvantaged groups that I have a particular research interest in, including low-income Americans. And in patients with chronic pain and their treatment, we see that some of the prescribing factors that are commonly observed have also been linked in the literature to adverse opioid-related outcomes. So individuals with chronic pain and prescription opioid use often have long-term use. Their episodes tend to be marked by higher dosages, and they're likely to be prescribed Schedule II drugs that have high abuse potential. So in part, this group was sort of a natural target for some of the early interventions trying to address the epidemic, and those focused primarily on reducing adverse outcomes by reducing opioid prescribing. But later studies emerged showing that there were unintended consequences potentially associated with some of these interventions, particularly for patients that were discontinued from their medication abruptly. So the CDC and other clinical and professional bodies have published recommendations since then to try to help guide opioid tapering practices in patients with chronic pain or patients that are expected to be taken off of opioids. The CDC recommendations in particular focus on higher risk groups, and they leave space open, sort of acknowledging that a one-size-fits-all approach may not be appropriate, but that individualized tapering practices might be more effective. So those guidelines recommend considering tapering for patients that don't show any improvement in pain or function when they reach a high dosage, defined as at least 90 morphine milligram equivalents, or for patients that show dose escalation. And the recommendation is to start by decreasing the dosage by 10% per week. But again, they sort of acknowledge the potential need for flexibility here, and say sort of more broadly that the taper just needs to be slow enough to minimize withdrawal signs and symptoms. And in particular, these slower tapers might be important for people who have been on prescription opioids for a long period of time. So the goal of the current study was really twofold. First, to identify trajectories of new long-term prescription opioid episodes in patients with non-cancer chronic pain, and then to examine the association between those patterns and patient characteristics, medication factors, and ultimately the development of opioid-related outcomes. The data used were MarketScan's Medicaid claims from 2013 to 2018. The sample included adults 18 to 64 at the time of prescription opioid initiation, which was defined as at least a 180-day baseline period with no prescription opioids before an index claim. Patients had to have a chronic pain diagnosis in that 180-day baseline period and couldn't have a diagnosis of cancer or opioid use disorder or any evidence of overdose-related treatment. And then we further focus on these sort of high-risk treatment episodes. So looking at those that were longer term, at least 90 days, and more consistent or episodes that reflected sort of more regular use. So they had to have prescription opioid supply in at least 50% of days in the treatment episode and no gaps greater than 30 days. The patient variables we measured were demographics, so sex, age, race, ethnicity, and insurance plan type, which was dichotomized as fee-for-service or managed care. And then a number of clinical characteristics that you'll see in more detail, but common mental health and substance use disorder diagnoses, a number of medical conditions, and baseline health service use. And then again, we looked at the proportion of days covered by prescription opioids, a standardized dosage measure, so morphine milligram equivalents, which I assume most people are familiar with, and the opioid type. Before moving into the analyses and results, I actually think it's helpful to sort of visualize the sample selection and sample size, because I think this in and of itself has important implications. So there were about 1.5 million adults that had new prescription opioid episodes. These episodes, or these people, had to have a continuous enrollment, so for the 6 months before they initiated and the 6 months after they discontinued prescription opioids. After applying all the baseline criteria, so ensuring they had a chronic pain diagnosis, no cancer, and no baseline treatment for opioid use disorder or overdose, we were left with about 600,000 non-cancer chronic pain patients with new episodes. And over half of those episodes were short-term, so less than 90 days. Of those that were long-term, the vast majority, 93%, were marked by use that wasn't regular, right? So with a pretty low standard in my humble opinion. So they either had supply on less than 50% of the days throughout the treatment episode, or gaps in supply greater than 30 days. And then of those that were actually long-term and reflected regular use, most episodes also never reached a high dosage using the threshold of 90 morphine milligram equivalents. So overall, these treatment episodes were pretty low risk. We focused on, I don't know if you guys can see my pointer, but we focused on this last box on the left, patients with these long-term consistent use high dosage episodes, and that left us with about 3,300 patients in the sample. So in focusing on these sort of high-risk treatment episodes, we were interested in characterizing their patterns of use and and particularly because these episodes aligned with the sort of CDC guidelines and recommendations for tapering and have been identified as, targets for intervention to potentially address opioid abuse and addiction and overdose. We use group-based trajectory models, which for those of you who are unfamiliar, is an approach that's actually been used for a couple of decades, primarily in developmental psychology and criminology, but has relatively recently gained traction in the clinical and epidemiologic spaces, and has really become an important tool for studying patterns of prescription drug use over time. The method is founded in latent variable analysis, so it can really be thought of as defining longitudinal latent classes that include, distinct groups of individuals that follow a similar path over time. The advantages of this approach over some of the more traditional methods is that it's flexible. So there are no a priori assumptions that have to be made about the number of groups or the shape of their trajectories. And so as a result, it ends up capturing sort of real variation across patient populations or study groups if you're not looking at patients. So because there's a pretty wide range in the duration of treatment for some of these individuals, we restricted it to those that reached their highest dosage in the last 6 months of treatment. So we could really focus in on trajectories at the end of the treatment period prior to discontinuation. We estimated trajectories from the time when the patient reached their maximum dosage, the highest morphine milligram equivalents in the episode, until the time of discontinuation, in hopes of really distinguishing any tapering practices that might be occurring. And we looked at the dosage outcome as a percentage of the maximum MME that was observed during the treatment episode. So the hope there was, if we saw any tapering, we could compare that with the CDC recommendations of 10% per week to really look at, how much of any tapering practices that are occurring are sort of guideline concordant. So after further limiting the sample, we were left with about 2,000 people. This figure shows the results of the trajectory analysis. So the yellow line at the top is a group that had pretty consistently high dosage and sort of fell off a cliff, so to speak. So on the x-axis, we have the weeks prior to discontinuation. This is in 7-day periods in the last 6 months of treatment. So on the far right-hand side, you're seeing the weeks just before discontinuing opioids. So everybody in the sample goes to 0 MME after the last time point on the x-axis. And then the y-axis is the percentage of their maximum dose. So you can sort of see how the dosage declined or the rate decline over time. And then the other two groups, the blue and green lines on the figure, are showing pretty steady tapering patterns toward the end of the episode, with one group on the blue line showing tapering to a pretty low dosage and the green line showing tapering to about a mid-level dosage. So if we look in more detail at some of the characteristics of dosage and change in dosage over time across those groups, we see a pretty clear gradient. The group that tapered to a low dosage in the week before they discontinued had on average about 25 MMEs, which represented about 20% of their maximum dose. The group that tapered to the mid-level dose was at about 50 MMEs, which represented about 42% of their maximum dosage. And then the group that didn't taper, the high dose group, ended on a pretty high dose. So on average, about 115 to 120 morphine milligram equivalents, which was pretty close to their maximum dose, so about 85% overall of their maximum dosage. And then looking at changes over this time period, so the group that tapered to a low dose overall on average had a dose reduction of about 75 MME, which represented about a 50% reduction in dosage. The group that tapered to a mid-level dose had about 53 MME reduction, which was about 38% of their maximum, and the no taper group really had no change over the period. And so translating that to sort of a percent change per week and thinking about the CDC guidelines, these are pretty slow tapers. So the group that tapered to a low dose had the sort of fastest taper at 2% per week, and the group that tapered to a mid-level dose was about 1.5% per week. And then looking even further at some of the episode characteristics across these various groups, we still see a gradient. So in terms of the length of the episode, the group that tapered to a lower dosage had the shortest episodes on average, increasing as you go across the groups. Looking at daily dosage, again, in morphine milligram equivalents, we see that across the episode, the group that tapered to a low dose had the lowest daily dosage, increasing across the groups. Similarly, when we look at the average dosage only on the days that had opioid supply, the maximum dosage was roughly similar between the two groups that tapered, but the group that didn't taper, the group with abrupt discontinuation, had a higher maximum dose. And they also had more opioid coverage. So the proportion of days covered by prescription opioid supply was roughly 88%, and it was lower among the groups that tapered. So this, in sort of a crude way, lumping in the tapering groups together, we used logistic regression to look at characteristics that predicted membership in the group with abrupt discontinuation. So these odds ratios are compared to individuals that fell in either tapering group, the risk associated with being someone that was abruptly discontinued from opioids at the end of the episode. And I think interestingly, we see that really no demographic characteristics were associated with abrupt discontinuation. One important characteristic that was the insurance plan. So, you have to do a little bit of mental flipping here, but fee-for-service plans, individuals enrolled in fee-for-service plans, were associated with membership in the group with abrupt discontinuation, whereas managed care was associated with tapering patterns. Again, we sort of see largely no mental health or substance use disorders were strongly associated with abrupt discontinuation. The one exception being tobacco use disorder. So it's sort of an interesting association. So individuals with tobacco use disorder were less likely to be abruptly discontinued. In my mind, and this is something potentially worth exploring more. This is a disorder I think that doesn't often get diagnosed, so potentially it could be sort of a proxy for the quality of care patients are receiving. And then now we finally start to see a little bit more movement in terms of predictors of abrupt discontinuation. So patients' baseline pain conditions or diagnoses were pretty strongly associated with patterns of prescription opioid use and discontinuation. So patients with generalized pain or back and neck pain had higher odds of membership in the group that was abruptly discontinued, whereas patients with baseline joint pain were less likely to be abruptly discontinued, so more likely to be in one of the tapering groups. But no other of the medical conditions we looked at, including the Elix-Hauser Index, which is just sort of a composite measure of overall medical burden, were strongly associated with trajectory patterns. And again, largely health service use at baseline was also not associated with treatment patterns, with the one exception being inpatient services. So,
Hillary, did you include the receiving a diagnosis of opioid use disorder in these variables?
People with opioid use disorder at baseline were excluded because we were interested in sort of the development of opioid-related outcomes.
Oh, interesting. Okay, thank you.
Mm-hmm.
You could think about just exploring broadening of that a little bit in later analyses.
Yeah, I mean, I think there are a number of opportunities to broaden this and think about other ways of figuring out.
One gets the impression from Tammy Mark's work and others that people go along, they're using prescribed drugs, and then they get this diagnosis of opioid use disorder, and that might be associated with then having an abrupt taper.
Yeah. So stay tuned for the end of the slideshow where I start to look at what's happening during the treatment episode itself. So this is sort of a recap of the sample selection and sample size, but again, I think something important to think about. Overall, prescription opioid episodes in chronic pain patients really demonstrated very low risk characteristics for opioid-related harm. So most of the episodes were pretty short. Very few reflected regular use. And then even among those that were long-term and consistent, most were pretty low dosage overall, suggesting potentially that some of the recent efforts to curb opioid prescribing have achieved some success, but this study doesn't really provide concrete evidence of the explicit policy impact. Our group and others on this call are currently doing analyses looking specifically at some policies that have attempted to address sort of initial limits on opioid prescribing and other policies that would help build the evidence base on whether or not this is directly related to some of the interventions that have been implemented in the last few years. And we saw with the trajectory analyses that a substantial but concerning minority of episodes were indicative of abrupt discontinuation. And furthermore, those episodes were characterized by other high-risk characteristics. So they were longer, they had higher dosages on average, and more supply of prescription opioids. And the tapers that we did observe were pretty gradual. So you'll remember that the group that tapered to a low dose on average had a dose reduction rate of about 2% per week, with the group tapering to about a mid-level dose at 1.5% per week. So this is consistent with the CDC guidelines for long-term users, but interestingly, the recommended starting point of 10% per week is over 5 times higher than what we observed. So I think potentially more work would be useful in order to identify optimal tapering, not just broadly, but potentially across specific patient subgroups. And then again, the patient characteristics that we looked at were largely unrelated to opioid prescribing patterns. To me, indicating potentially that there are structural factors or provider characteristics that are also important or potentially more important. One such structural factor that is potentially a good target for future research are the insurance plan types. So we saw that managed care plans were associated with individuals following a tapering trajectory. The market scan data don't include plan characteristics, and I think some others in our group have attempted to look at this through for other medications have discovered that it's not always easy to find plan characteristics, but incorporating them into future research, I think, would be helpful to determine whether the relationship is really a direct result of benefit design and insurance policies, or whether it's sort of an artifact of the differences in the populations that enroll in fee-for-service versus managed care plans. So those differences could potentially be sucking up some of the individual characteristics that weren't associated with the trajectories. And then finally, we saw that generalized pain and back and neck pain were associated with abrupt discontinuation. To me, this sort of suggests there might be differences in treatment for some of these less definitive pain conditions that is potentially worth exploring in subgroup analyses or looking at in the future. And so, Steve, here's some of what I mentioned to you a few minutes ago. So, the next step is, I think, really to look at opioid-related outcomes that occur during the prescription opioid treatment episode and after discontinuation, to sort of better understand the relationship between trajectories and outcomes. So this table is showing you the outcome is a combination of any incident OUD diagnosis or medical treatment for opioid overdose and other opioid-related events. And, broadly, again, we see a gradient with, most people having none of these outcomes either during treatment or follow-up, but pretty high numbers, even for the group that tapered to a low dose, of any of these adverse outcomes, both during treatment and follow-up. And so, whether these differences are significant in adjusted analyses is sort of to be determined, but the no tapering group, the high dosage group, had 12% that had any of these outcomes during treatment. And, sort of to your point, Steve, you would expect that for individuals who had these outcomes, potentially a taper or a transition to buprenorphine or another medication for opioid use disorder might be indicated. But instead, they were potentially abruptly discontinued. So some of these, I think, outcomes in the next analytic steps will be important for thinking about ways to improve the quality of care for people who do develop problems specifically, both during treatment and at follow-up. So with that, I will open it up to further discussion. But first, I want to thank all of you for joining, and my co-authors, Dr. Crystal, who you've heard from throughout the talk, and our colleagues at Columbia, and my funding from NIDA through the K01.
That was awesome, Hillary. Thank you so much. I guess if we'd open up to questions at this point. I know that I had a quick question, and that's about provider characteristics. And do you think it would be helpful to better understand that with the patterns you observed?
Yeah, so can I go back? Yeah, so as I mentioned earlier, market scan doesn't include some of the things that I think are potentially important to look at in future studies. Provider characteristics are one set of variables that in every claims analysis I've ever done, I think would be more helpful to have. So, starting with characteristics that are available in, other data sets potentially, I think, the provider specialty could be pretty important, which would give a better sense of sort of the setting of care for some of these patients. And, whether this is a primary care physician or it's a specialized pain clinic or that kind of thing. But even more than that, I mean, potentially, like with the last bullet point, the generalized pain and back and neck pain, there could be some stigma playing in here, right? Like if you have a diagnosis of joint pain because arthritis has been observed in your knee after an injury or something, maybe that pain is believed better, or you have thoughts about somebody that comes in and the diagnosis that you put down on the billing sheet is generalized pain or chronic pain or headaches, which aren't very well understood and fall into that category.
Or fibromyalgia.
Or fibromyalgia, which I actually can't remember I don't know that I put that in that category or included it, but it's probably there.
Yeah, these diagnoses being perceived as psychogenic in some cases.
And maybe that's where I think it's the ICD-9 ones I'm thinking of, but there are a couple of diagnosis codes that are in that category that are, the word isn't psychosomatic, but it's like pain of psychological origins or something.
Right.
So I think, beyond some of the characteristics that are typical in sort of formal data sets, claims data or survey data or that kind of thing, it would be really interesting to have more qualitative data on provider characteristics in terms of their training and their biases and, those kinds of things. Thank you.
That
Hillary?
caused me to make a note that we have to do something about getting the provider file for TAF, because that gives the provider specialties and some of the
Oh, yeah.
characteristics.
Yeah, that would be great.
Yeah. Sherry, I think you were asking something.
Yeah, sorry to interrupt. Hillary, thanks so much for this. It was great to see this all summarized. I've read the paper, but I feel like now I know this much better. One question I have, I understand you don't have provider characteristics, but are you certain that the person who was prescribing and doing the tapering is the same person, the
Nope.
same clinician?
Nope, and that's a good point. So it would,
Okay.
I mean, provider characteristics would illuminate that, right? In
Yeah,
some ways. Yeah, so the prescription drug claims, which I'm pretty sure is the case for all claims data sets, doesn't, well, maybe not, maybe there are a couple, but doesn't include like a provider ID. At least in Market Scan, it's a pharmacy ID, and it's very poorly populated, so there's a lot of missing
I
data.
see.
Another thing that wouldn't be captured here are patients who pay in cash. So maybe it looks like they discontinued, but they really didn't. They were told, there was some cap related to insurance, and they switched to cash payment. That's probably a pretty small proportion, considering these are Medicaid enrollees, therefore primarily low-income adults, right? But there could be other sort of missing features of, either switching prescribers or switching payment forms or other things that are missed.
Mm-hmm. Thank you.
Mhm.
Hillary, I have a question. I'm sorry.
Go ahead.
Thanks. I was just wondering if there were any variables around whether participants were pediatric patients, because I know sometimes with that transition for patients with genetic pain conditions, it may make a difference how they were treated in a pediatric setting versus an adult care setting in terms of that trajectory for potential opioid prescription use and dependency that may be developed as an adult. So I don't know, it may be too much to ask for in the data set, but I'm wondering what the implications were for folks transitioning from pediatric care to adult care in terms of pain management.
Yeah, I mean, so the sample was limited to adults. There's no indicator for prior care, although it's something that could certainly be looked at, provided they were continuously enrolled throughout that period, right? If they switched insurance at any point or ended up with a new enrollee ID when they switched off their dependent plan to their adult plan, it's complicated. That said, I mean, I have the baseline pain diagnosis, and of course there are like congenital deformities and, like bone-related conditions, spinal conditions, scoliosis, those kinds of things. So, in theory, you could at least look at those conditions, but the sample size for claims analysis, this is probably the smallest sample size I've ever seen. So I would imagine limiting to those conditions would be sort of prohibitive in terms of at least assessing the significant differences or, looking at patterns. So unfortunately, no.
But when we move to the TAF, you'll have a little more, power to do that, because that'll be 50 state data. And I think the subgroup that Anais would be particularly interested in would be those with sickle cell anemia.
Yeah, and you could certainly, I mean, you could redo the analysis in a different population and just look at kids who are still kids, right? Limited to an adolescent sample, and look at it there. There are a lot of kids on Medicaid and in the data, so you probably, even with Market Scan, get a bigger sample size.
Hillary, another thing you might want to consider is, because I agree with Ines, the transition age group, I think, is a really important group when you're thinking about addiction. So, and comorbid mental health conditions, as well as substance use conditions. I'm pressing people to think about this sort of adolescence, young adulthood as being a different age range, like say 14 to 25 or something like that, just because I think that those people experience the system completely differently. They're also relying on themselves more than sort of guidance around medical care. It would just be very interesting to see what happens for those young people.
Agreed.
I'm gonna monitor the chat. So if any of our, particularly the folks outside our center, want to get a question in, just put something in the chat, and we'll make sure to get you in.
Yeah, I got a message from Anthony Gonzalez who
Yeah, here's
asked
Anthony. So Anthony.
whether I did any analysis by zip code or provider setting, because he was wondering if abrupt discontinuation could be higher in acute care settings where follow-up is unlikely. Zip codes aren't available, unfortunately, in these data, so there's no way to sort of do anything geographically. But as Steve was mentioning, some of the other data sets we have in the center or institute, that would be possible using some of those data sets. Also possible, I mean, the K is actually to use those data, so this is sort of really a preliminary analysis because I started it before I had access to the data through the K. But the plan is to look at both county level and state level characteristics ultimately in sort of a multi-level analysis. So you've got this first level of patient factors and tapering patterns, and then at the county level, availability of hospital services, whether it's a primary care shortage area, mental health care shortage area, those kinds of things, along with, of course, county level like population characteristics, and then state level policies. So some of the opioid prescribing policies, Medicaid expansion, and those kinds of things. So stay tuned, Anthony, in the next couple of years. Hopefully we'll see lots of results related to that. It would
just as something of interest maybe to the larger group, we're sort of gradually getting on top of the data through 2016, the TMSIS analytic files, which is 50 states. So when you think about sort of comparing it to what Hillary had to work with in the market scan, it's something like 8 states and not necessarily the biggest. So, and this is particularly relevant to Radha, who is now working with us, and we want everybody to greet Radha, our newest member, who and one of the things that she'll be doing is helping us to make sense of those data and do the necessary checks to make sure that we don't have state years that we need to exclude for incomplete data on one type of encounter or another, and so forth. But once we get those data up and running, we will have, Hillary will have a zip code level, correct?
Yeah.
As well as counties.
Yeah, I'll be doing the analysis at the county level, but yeah.
And then to Anthony's question, at that point, we'll be able to link, probably mostly on the county level, the various demographic characteristics, including racial, ethnic composition of the areas. It would be nice if we could go down below zip codes, but we probably can't. But what we do have in those data, we'll have patient level race, ethnicity, which when we have a larger sample, we could look for equity issues in these tapering analyses. So that's kind of the directions that we'll be able to go once we're really fully up to speed on the TAF data. If there's other questions, again, I had a couple that I was thinking about. The initial flow chart is very interesting, and some of the some of the comments that you made in the conclusions that were from the larger perspective, I think could be important in the paper, because what's obviously surprising to me is how many of these people, how few of these people finally made it to the long-term consistent use high dosage episodes. And this is which years, Hillary?
2013 to 2018.
2013 to 2018. Did you make any effort? I realize that this is just the setup get to your population for the trajectory modeling. But could you see if there's a trend in towards that last category becoming smaller relative to the whole over time?
I could, yeah, I mean, at the very least, I could look at whether most of the episodes in that group tended to be initiated in later years.
Yeah, yeah. I was quite surprised that it's so you start with these almost 1.5 million new episodes. And then first, it's very interesting that half of them don't have the chronic pain diagnosis. That's kind of odd.
Well, I mean, they could have been a single prescription opioid
Yeah.
Claim for a dental procedure or something, right?
Yeah, yeah. The number of exclusions for OUD is actually small, but then the big drop off, you get to this 601, and more than half of them are less than 90 days. And then this sporadic supply is kind of among those with more than 90 days. The sporadic supply is actually very much the modal category.
Yeah, so when you were talking about, I don't know if we'd gotten to the slide yet, but potentially expanding to individuals who had opioid problems at baseline,
Yeah.
I am inclined first, if I were going to expand, to look at episodes with sporadic supply, because in some ways those people might be the most high risk people, right? If your trajectory is this,
right,
as opposed to this, or even steady flat, at a high dose, those trajectories might be the ones where we're really seeing issues. And they sort of get at things that we've talked about quite a bit, at least in our smaller groups, about discontinuation, right? If you aren't being consistently, if your opioid use isn't consistently supervised by a provider, or maybe it's, to Sherry's point, that somebody's switching providers, those people might actually be at highest risk because either they're not followed closely, or they just have these intermittent problems, or, they're building up tolerance and it's dropping, and they're building it up and it's dropping. So
yeah, exactly, something like that. Much more. And actually, all of these phenomena, if you think about it, we want analytically to treat them as like particular episodes of something. So you have an episode of opioid use, or you have an episode of MOUD, for that matter. But then when you kind of expand your lens and start thinking about what patterns over longer periods of time really look like, they're very episodic and in and out. And we probably see the same thing with MOUD, which I think is going to be interesting in its own way. The other sort of slight shift of perspective that I've been having lately, just thinking about opioid use, and it comes in part from the paper that Sharon and I worked on, and contributed some tables to this very large international collaboration. Sharon, I don't know if you want to comment, but I was struck by how, and this is on simple measures of opioid use and trends, but I was struck by how the United States looks a lot less like an international collaborator than international outlier, than we'd sort of been led to think. Sharon, was that your impression as well?
Yes, it definitely was. And the decreases looked, I mean, when you look at the results, the decreases look,
So there's this kind of, model that's been set up in everybody's mind that kind of in the United States, we kind of went crazy with opioid prescribing and created all these problems. And it's a more complex problem than that, but it's also not so distinctly American as sort of the image in many cases has been. And part of that seems to be that, we had this image that we were just sort of, all these people were being iatrogenically made dependent on opioids to manage their pain, and then just put on autopilot for years and years at very high doses. And we had created this monster, and they're constantly escalating their doses. And when you look at it from the lens, Hillary, that you've been doing, it's a much more complex problem, and it looks like, people have ups and downs. They have acute episodes in their pain, and maybe they get prescribed, and then they in many cases will stretch their prescriptions, which I suspect is what you're seeing in that sporadic group, is people are getting these prescriptions. They get 30 oxys, and it says on the script that that's 30 days supply, or whatever number it is. But then, they make it last for 3 months, and then they go back and get another one, something like that. So a lot of it, starts looking like PRN rather than people, in which case, hopefully they don't have as great physiological dependence.
Mhm.
So there's a lot that's very cool here.
Yeah, and a lot of possibilities moving forward, I think, too.
And I was trying to think if there's more. You got a little bit of mileage with the consequences, but maybe there's ways that you could dig in a little bit more to try to find markers for the consequences. But what you need for this analysis is a bigger group than this 33-41 somehow.
Yeah.
And maybe you can get that from TAF, or maybe you can get it from Medicare. The managed care variable is fascinating.
Yeah, that ugly variable rears its head again. Another thing that I've, in almost every claims analysis, wish I had more details about are the plan characteristics themselves.
Yep. Well, we need to ultimately go beyond in the Medicare data. Managed care data are available now, but at the Institute, we only have the Part D data. So, I don't know how we get past that, because that's another enormously expensive data purchase. But in the Medicare population, it would be interesting. But maybe we can make headway in the Medicaid population, and that's the other file, not terribly expensive, but we just have to go through the process of getting it. That's the plan characteristics file for TAF. And that was one of the motivations for having TAF in the first place, is that you could get more granular on things like plans and providers. So Sharon, we should talk separately, because we need to follow up with pets and try to get that in progress. So I've talked too much, but does anybody else want to jump in and sort of ask a final question or two, or make a comment?
A comment from Jay in the chat.
Oh, great. Jay, why don't you take yourself off mute and make your comment directly?
I was wondering whether or not there was any data on suicides. We have a couple studies in the NIMH Center where we receive blood samples from suicides. Obviously, they're difficult to collect. And to the best of my knowledge, there's no data on drugs in the bloodstream at the time of death. And I was just curious what the relationship, obviously there are going to be a lot of different drugs. It's not going to be only opiates.
Yeah. I mean, so one of the sort of later next steps, once I start looking at the NACS and TAF data, which will be linked with the National Death Index data, is to look not only at accidental overdose and medically treated, non-fatal overdose, but also suicides. That doesn't really answer your question.
No, I didn't expect.
But it's, I mean, I agree that it's a really interesting one. And of course, some states are pretty good at tracing back potential suicides, trying to identify potentially intentional overdoses in contrast to accidental ones. But
I mean, I would say
is,
that, go ahead.
This is all kinds of suicides by gun or jumping off a roof. We've learned that because of the difficulties in collection, as you might imagine.
So Jay, when you said that there are no data on drugs in the blood of people, you mean there are no data that sort of precede the samples that you have?
Well, again, these are not my studies. These are studies we have. We have one in Utah and one that's nationwide.
Right.
There are medical records, but I think there's an interesting question: what's going on at the time of death? If death is violent and sudden,
right?
Overdose, you kind of know.
I don't know if Molly is on. Molly is going to be looking sort of at a number of the overdose issues in the Medicare population for her dissertation. I see that she's here. It's something we've talked about with Paul Duberstein. And if there's any way to get a signal on completed suicides, the data set that we'll find it in is in the either the 50%, roughly 50% Medicare or 100% Medicare with the NDI match. That I don't know if you, Molly, if you want to sort of, talk a little bit about, just say a couple things about what you think you might be able to do.
Sure. I mean, so my dissertation is focusing on a different patient population, but with the NDI match, we can definitely see who is dying by suicide and possibly, potentially the means of suicide, right? So we can look at people who die by drug overdose. And so that's like one, subgroup of the suicides that I think we're interested in, that I'm interested in for my dissertation, but also, of course, very relevant for this work.
Yeah, I mean, another thing I've thought about is, and I think Molly, you've maybe been doing this too, or thinking about it too, is looking at self-harm codes. Also Jay doesn't really get at exactly what you're interested in, but the association of potentially of abrupt discontinuation or other patterns, treatment patterns that we see over the course of the episode and their relationship with self-harm and suicidal attempts could be interesting.
I don't look at it because it's not my purview, but we have clinical data that's whatever's available, as well as certain psychiatric measurements on these subjects. Eventually, all this data goes into, I'm not familiar with NDI, I am familiar with NDA, which is a database that harbors the information, the genetic and phenotypic information on various subjects in various studies. It's a requirement that the data be submitted to NDA, and then any legitimate researcher can access it.
That's great. Yeah, I have a colleague who does some substance use and mental health stuff using the biobank genetic data. Yeah, the NDI is just the National Death Index, so it's death records with ICD codes.
Not one I use.
I was wondering if there's...
Georgette, we were supposed to be 1 hour, right?
Yes, we were, but it was so interesting that, we've gone over. So there we have it.
Yeah. Well, this is fantastic.
Yeah, thank you all for coming. If you have other questions, feel free to connect via email, or Anthony, I can stay on for a minute if you want to ask your question after everybody leaves.
Sure.
Great, and the video will be available on the Special Populations website next week. So if anyone wants to review the information, feel free to do so.
Awesome. Well, thank you. This was wonderful.